Well, thank you very much, Hanita. It's a pleasure to be here, and thank you for the invitation. I've been working with Hanita lenses for the last over 20 years, I think now. So it's a joy, and they really need a lot of advancement and progress, and we should really appreciate it. So thank you very much for all the effort. I will take you through the more complicated part of our professional life, and this is treating lens subluxation. And subluxated lens means that the lens is not in place. The fibers, the zonals which hold the lens in place are either missing, torn, or are weakened, and that may occur either with a crystalline lens, the natural clear lens, or intraocular lens. And let's start first with the crystalline lens. In this case, what are the options? We can either remove the entire lens and then put an alternative lens in the eye, anterior chamber lens or posterior chamber lens, fixated to the sclera or to the iris. Or the other option is to preserve the lens capsule for fixation of a intraocular lens. But in this case, we may need a capsule stabilizing devices. Now, why should we maintain the posterior capsule? First of all, we maintain the barrier between the anterior and the posterior segments of the eye. We utilize the remaining of the zonals. They keep the lens centered. They prevent the tilt. The lens is away, no contact with any of the adjacent tissue. It is a natural location. So this is what we would like to have as a final result. How can we do it? There are two kinds today of capsule stabilizing devices. One is equatorial support. This is what we have now in the market. And the second one is the anterior capsular support, and this is a new approach that we are now presenting. As for the equatorial support, it means that a device that would occupy the entire lens capsule, and if the zonals are missing of 3 hours, clock hours, 1/4 of the circumference or less, then we can just use a capsular tension ring, the same one as we have from Hanita. It is just a ring, and that can suffice. But if it is more than 3 hours, then we need something else. And the most common result, what is used today, is a ring, equatorial ring, which has an extension. This is a Sioni ring that bypasses the capsular axis, and it is fixated to the scleral wall. Now, and this is an example of how it works. The Sioni has either one extension or two extensions, but it is not very easy to put in the eye. You need to open up the entire lens equator. The other option is Ahmed segment, which is a smaller segment, make it easier to implant. And Boris Malyugin modified it to have an extension at the terminal, so it can also be injected. Now, what we suggest is a totally different concept. And this is a capsular anchor, which actually is an anterior capsular support. It looks like an anchor, and actually this is what it does. It anchors the anterior capsule to the scleral wall. And it actually works as a clip. As we can see, it has two lateral arms which are located behind the anterior capsule, and the central part which is sutured to the sclera. And we can see in this animation how it works. We have a suture going from the sclera through the main incision, either through the hole here or wraps around and out again. The two lateral arms are located behind, the anterior part is in front, and in this oblique view, we will see it better, the two lateral arms are located behind the capsule, the anterior part is up front, so it actually acts as a clip. It's a capsular clip, and now when the lens is in the natural position, we can do the routine cautious phacoemulsification and implant any kind of a posterior chamber lens like the C lens that we see here. So let's see some clinical cases, and this is the first case is a Marfan syndrome. The inferior zonals are missing, so we have a needle coming from the outside through the main incision, going back again, so we create a kind of a loop, and in this case, we wrap around the central part, put the device in. This is 2.5 millimeters side to side, so it can easily go through any routine incision. We clip it to the anterior capsule and suture, so now the lens is back in place. We can do routine, cautious phacoemulsification and implant a lens, practically any kind of a lens that can go into the eye very cautiously, and now it's well centered. The next case is also for Marfan syndrome. Again, the zonos are missing here. Stitch going from the outside, main incision back again, and the anchor is inserted in place, and now it brings the entire lens into place. We can do the phacoemulsification, only that in this case, when we aspirated the lens material, we saw there are some zonos are missing here too. So if it works one time, it can work also for the second time, and a second anchor was used in order to anchor the area here. We also use a safety suture. That means that we implanted the anchor, making sure that it is now secure to the scleral wall, and only now the safety suture was removed. Since it is kind of a ring suture, we can bury it in the scleral tissue, no need for any scleral flaps, and the lens is well centered. This is the case of a patient after trauma. Part of the capsule is missing here. So we need to bend the needle here because the nose is here. Nose is unnecessary organ, but it's there. So we go with the needle from the outside, anchor the lens equator to the scleral wall, and once it is there, we can just aspirate the lens material. This is a young patient, typical to trauma. We can remove the lens, implant a posterior chamber lens within the bag. And then, since we are now having a part of the iris is missing, we can also do pupilloplasty or iridoplasty and cover the missing area, and this is at the end of the operation. Next case, this is a +4 nuclear sclerotic lens. About 1/3 of the zonos are missing, and as you can see here, I'm threading the needle, the suture, through the device. And this is probably the better way to do it, to go through, not around it, because it makes it safer. And even though this was a very hard, solid, hard rock lens, we could take it out and implant a posterior chamber lens within the bag. This is another case of a Marfan syndrome. And what we learned from our experience that there are some ways to make it easier. Number one, to thread it through the positioning hole at the base of the device. Number two is to do a very good iododissection and a viscodissection to separate between the capsule and the lens material. And then put the device, it goes easily in. And then we can do the phacoemulsification. And one other thing, this suture should not be over tight, just a little, just a positional, and that's all that is required. And from there on, lens removal is done in a routine fashion. Aspiration of the cortical material and implantation of a posterior chamber lens is in the bag. And this is the last case. This is a young baby. You see a lot of the zonos are missing, so we put one anchor in. We could take it all the way to the other side and aspirate the lens material. But in this case, we wanted to maintain the contour of the lens equator, so we also injected a capsular tension ring. So capsular tension ring can go in conjunction with the capsular anchor. You can separate the two, but note that the equator here is almost, it's very central. So some of the zonos are missing here. So we also implanted a second anchor at the end of the operation. So we have one anchor at the beginning of the operation, a second anchor at the very end of the operation. So this is how it works for subluxation of the crystalline lens, and here are some clinical results. This is what the eyes looks like. And it's stable, it's central, and actually it works for every lens that we have. The eye look quiet, and as we can see, the suture here is buried under the conjunctiva, no need for any scleral flaps. And these are some of the clinical results just to show you how repeatable it is. So far, we had 25 patients with 21 patients, 25 anchors, and some of them we have 6 patients. We use the capsular tension ring. Some of them we use 2 anchors in one eye, follow up over 4 years, and all of them, as far as I know, are still stable and central. Now, let me just take you a little bit and do it shortly, subluxation of the IOL. Now, everything that we said about subluxation of the crystalline lens works also for subluxation of intraocular lens. Surgical option are either to remove the lens, the IOL, or then put an alternative lens, or to preserve the lens and fixate it either to the sclera or the iris, or use one of these capsule stabilizing devices. Now, to remove the entire lens doesn't make any sense, because then you need to make a very large incision, at least 3 millimeter, sometimes up to 7 if it is a solid lens. Then you need to do all the manipulations in the anterior chamber, which are risky, and then put an alternative lens. Another option, the lens is good. We don't need to remove it. What we can do, the problem is it is malpositioned, so we can reposition and refixate the same lens. And just to show you some example of how it can be done with a lens which is misplaced, now it is properly centered, and one more example, and one more example. So we can do it either with fixation to the iris, fixation to the sclera. I will not go over some of the surgical techniques, but if we do that, we just have 2-point fixation. The lens may tilt. So maybe we can use one of these devices. With the ring, it doesn't work. We need to open up the entire lens equator. That's too much. To have a segment, it's feasible, but it's very difficult. But we can utilize the capsular anchor also for subluxated intraocular lenses, and the reason is that we don't need to open the equator. All we need is to open just a small pocket here. That's 2.5 millimeters, so all we need is about 3.5 millimeters. That's about 2 clock hours, and then we can use it to refixate the lens. And here, one posterior chamber lens, the donors are missing here, so we create a pocket. We inject some viscoelastic to separate the capsule from the IOL, thread the needle from the sclera out through the anchor and back again, and put the anchor in place using intraocular forceps, making sure that one leg is behind. Now the second arm is behind the capsule, central part is up front. We suture it, we close it and bury the knot, and actually this is it. Now the lens, the intraocular lens, the misplaced lens is now back in place, well centered. And this is the second case I'm going to show you. Now it is drawn downwards. Zones are missing here. We create a pocket, insert the needle, put the anchor in place, and suture it. And once again, I would emphasize we do not need to tight it here, which I probably did, but it's well centered and stable, and it is stable today. So just, and I have a few cases of those, so just to summarize, the anchor can be used either for subluxation of crystalline lens and a posterior chamber lens, and preserves the capsule in the absence of or weakness of the zonus. And I thank you very much.